Good morning. At the outset, it's a privilege to be here uh, eh, for this update, for this refresher course, and I thank Rajesh and the team here at BRiCC for having me over for this program. Now, in the next 20 minutes or so, I'm going to take you through what you can expect to know about sepsis as an update, but I'm not going to bombard you and tax your intelligence by talking about the Surviving Sepsis campaign and telling you should give 30 mils per kilogram of fluids, look at lactate, give early appropriate antibiotics. All of you have been bombarded with it, and that topic has been beaten to pulp. So I'm not going to go in that direction at all. I'm going to give you a perspective about what is going to be the future and what you need to know as far as the pathogenesis and the behavior of sepsis is concerned. So, as you can see from this diagram, there are several aspects which make a person susceptible to sepsis. It's not just chronic diseases, but the acute disease like sepsis also has certain predeterminant factors which influence its outcome. So, if you look at age, comorbidity, source of infection, causative organism, and the appropriateness or the inappropriateness of your treatment will have a bearing on how the sepsis outcome ultimately turns out to be. And then currently, we are looking at metabolites of the organisms, the response of the body to these organisms, and the metabolites which are generated thereof, the mRNA that is generated, and all this contributing to the cellular function and the phenotype of sepsis. Now, this is going to be the crux. Those of you who are going to appear for DRNB and DM exams are expected to know the phenotypes of sepsis. There are 4 phenotypes of sepsis: alpha, beta, delta, gamma. You need to know which is where, which organ manifestation is predominant in which phenotype of sepsis, and this is where it all starts from, resulting in either end organ injury or death. So this complex pathophysiology, this entire phenotyping of sepsis has emerged in the last couple of years, where COVID has taught us that it is not just a imbalance between pro and anti-inflammatory cytokines, but at some point of time during the course of sepsis, we face a situation of a cytokine storm, and that is what we are. Okay, that's what we are planning to. We look at any patient with sepsis, despite all the comorbidities we spoke about, reacts to the pathogen associated and the disease associated molecular patterns, resulting in an activation of the complement system. And this inflammatory response is now intrinsically linked to the coagulation system. We found during COVID that these patients have a high D-dimer, higher coagulation. Now that is now known not to be exclusive to COVID, it is exclusive to an inflammatory infective process. So that cytokine storm triggers a coagulation cascade, and this coagulation cascade will produce a lot of organ dysfunction, break down the barriers for resistance to infection, and result in organ failure. So there is some kind of overlap between the coagulation cascade, the cytokine storm, and the capillary dysfunction and the glycocalyx dysfunction that happens in sepsis. This is the latest understanding we have from the evidence we have accumulated over the last couple of years after the COVID pandemic. So this pattern results in a sequence of ups and downs in the coagulation, in the sepsis inflammatory pathway. Previously, when we were training, we were told that there is an ebb and flow hypothesis in sepsis. It is not as watertight as we were taught it was. It's not that a patient will spend in the ebb phase in the first 3 days and then go into the flow phase in the next 7 days. It's not as simple as that. Even in the early stage of sepsis, depending on different phenotypes of the patient, which we will discuss in the subsequent part of this presentation, the patients will have either a hyperinflammatory phase of sepsis or a hypoinflammatory phase of sepsis, similar to ARDS. You have a hyperinflammatory variant of ARDS and a hypoinflammatory variant of ARDS. You have a hyperinflammatory phase and a hypoinflammatory phase, and this fluctuates during the course of sepsis, and somewhere along the line, in the time frame, there is a phase of immunoparalysis, and we are not yet able to identify what is the biomarker or what is the clinical feature which indicates that somebody has immunoparalysis. Now, an immunoparalytic patient then becomes susceptible to nosocomial infections, and we don't yet know which is the phase of sepsis, at what point of time of these graphs if somebody goes into an immunoparalysis, so that we can prevent it. But what is important is this immunoparalysis makes these patients susceptible to nosocomial infections, viral reactivation, and endotoxin intolerance, which results in deterioration. But if they can overcome this phase of immunoparalysis and subsequently go on to mount an immune response, it results in recovery. This is the latest understanding of sepsis, away from the ebb and flow hypothesis, which we believed was the way sepsis behaves in the initial 48-72 hours and the subsequent time frame. There are several mediators for you to remember, but most importantly, our friends are back here, IL-6 and IL-8, which we were actually very meticulously tracking during the COVID pandemic. Again, these are not exclusive to COVID at all. These have always been present in sepsis, which are actually a marker of poor control of infection. So when you're looking at biomarkers, rather than get carried away by looking at CRP and procalcitonin as your markers of sepsis recovery or non-recovery, these are the markers which would probably tell you that your therapeutic strategy for your patient is not going in the right direction and the control of infection is very poor. So a rise in IL-6 and IL-8, as well as a complement consumption with a decrease in complement C3 and C4, are more reliable markers of poor response to your antimicrobial strategy than a rising procalcitonin or a non-resolving CRP. This is another latest understanding we have about the pathophysiology of sepsis. So that brings us to what biomarkers should we actually be looking at, right? We have understood that there is procalcitonin, there is pre-sepsin, and there is SUPAR, which were already present. We have CRP up there, and you have procalcitonin, which we already have been tracking for a long time. The new players seem to be IL-6 and TNF-alpha. Now, these seem to be easily trackable, more dynamic, more representative biomarkers, which will tell you whether your inflammatory process is at its peak or it is going into a immunoparalytic state. That is something we need to identify during the course of management of a patient with sepsis if you want to know whether your meropenem is working or your antifungal is working or your entire strategy is going in the wrong direction and you are looking at a non-septic process at all. If you look at the diagnostic accuracy of all these biomarkers, you need to know that the AU and ROC is the highest for CD64. It is much more than for procalcitonin. CRP underperforms when compared to procalcitonin because several non-infective processes can also result in a rise in CRP. But the ones which are more representative of a good septic process are pre-sepsin and CD64. Pre-sepsin has already been evaluated in a randomized controlled trial and has found to be better than procalcitonin in identifying non-response to infections, but the match is probably going to be played between CD64 and pre-sepsin in the future, and this is what you need to remember when you write your theory about emerging biomarkers in sepsis. The sepsis definition also has undergone a lot of changes, probably related to the understanding of the pathophysiology or the immunopathology which we have discussed. So we have the current definition which says that this is a dysregulated immune response to infection resulting in organ failure. So that is where we stand at the end of 2022 in terms of definition of sepsis. Sorry? Okay. So fluids have been another paradigm which has shifted very significantly in the last 15 years as far as sepsis is concerned. When we were training in critical care 20 years ago, we were taught that when there is a septic patient, you fill the patient, reassess the patient, fill them some more. That was what we were taught. But now we understand that early aggressive, late conservative fluid strategy, what is called as the EALC concept, is probably the best way of resuscitating these patients. And while we are resuscitating some patients, you may not be able to achieve the target map till you give the target fluid. So early initiation of vasopressors is also now considered as acceptable norm. So if you look at the 2001 paradigms of sepsis and then go through 2010 and go up to 2023, this is where we are at this point of time. You know a few things. colloids are bad. Starches should not be used. Albumin in very selected patients who are requiring large volume fluid resuscitation, whose albumin is less than 30 grams per liter, and always use a monitoring tool to identify those patients who have fluid overload and are leaking the fluid into the extravascular compartment. So this is what we understand, and between saline and balanced crystalloids in the initial stages of up to 30 mils per kilogram, there is no difference in outcomes. Beyond 30 mils, if you are giving a patient fluids or patient needs more fluids, then balanced crystalloids score over saline. Otherwise, saline and balanced crystalloids are comparable. Between the balanced crystalloids, there is nothing to choose between lactated ringers and the commercially available balanced crystalloids like plasmalite and stereofundin. When you look at vasopressors, initially it started with dopamine, and dopamine went out of fashion way back in the 2000. Slowly we progressed between vasopressin, norepinephrine, vasopressin, to the point that now norepinephrine is the vasopressor for all kinds of shock. And if your patient is requiring higher doses of norepinephrine or increasing dose of norepinephrine, consider adding a second vasopressor. And when you are considering adding a second vasopressor, that's when you should think adding hydrocortisone to your patient. Previously, again, we were taught that if you want to start norepinephrine for a patient, it should always through a central line. Now it is accepted that up to 0.5 mics of norepinephrine per minute, you could use it through a peripheral line for 4 to 6 hours before you can actually prioritize and make the patient stable enough for you to attempt a central line, because central line has its intrinsic problems and you need to make the procedure safer. So you know now that you can start vasopressors early. You should start a second vasopressor if you are not able within 6 hours, and a second vasopressor would mean you think about starting hydrocortisone for these patients. So if you look at the time points with septic shock, hypotension, and resuscitative fluid loading, so if you look at the time points, you start before or less than 30 to 90 minutes of ED arrival if your mean arterial pressure is less than 55. If you are starting a patient for fluid resuscitation with a MAP of less than 65, between 55 and 65, you can actually try with fluids without a vasopressor. But if you are starting your patient for resuscitation whose MAP is already 55 or lower, you have to start fluids with piggybacking with norepinephrine and wean it off. So this is called as resuscitative fluid loading, where you start the norepinephrine before you do the resuscitative fluid loading. And then you look at the dynamic compliance, and then you try to see whether there is a mono vasopressor therapy is enough or a dual vasopressor therapy is needed for these patients. So that brings us to the third vasopressor. We were always on the lookout for a third vasopressor. We knew that we had norepinephrine. We knew we had vasopressin. There are some people who believe that adrenaline is a good vasopressor, but in the context of sepsis and hyperlactatemia, we know that adrenaline is a lactate generator, so it may confound your measurement of lactate. So that set off this study for or search for the third vasopressor, and we now understood that there is something called as, just as we have relative adrenal insufficiency and relative vasopressin insufficiency in sepsis, you also have a relative renin deficiency in sepsis. And the renin-angiotensin-aldosterone axis is stimulated by as shown in the figure which we have demonstrated. So the use of angiotensin 2 seems to be the solution, because it totally acts on a different pathway. You have your sympathetic receptors, you have your aquaporin receptors, which are already being acted upon by your catecholamines and your vasopressin. You need a third mechanism by which you can optimize the blood pressure, and the most potent vasoconstrictor in human body is angiotensin 2. And that is what the Athos 3 trial tried to show us. It showed that initiation of angiotensin 2 in a patient who has a higher capillary refill time results in shorter time to reversal of shock, and subsequently lesser dose of norepinephrine, probably not translating into statistically significant mortality advantage, but there was a difference in the Kaplan-Meier curves in survival between the angiotensin 2 group and the non-angiotensin 2 group also. So as and when angiotensin 2 becomes available in the Indian market, it is probably going to be the third vasopressor of choice, or probably the second vasopressor of choice, if you have the if you have the measurement of plasma renin activity. One of my students back home in Hyderabad is actually working on it towards his DNB thesis, where we are measuring the plasma renin activity in patients on norepinephrine in septic shock who are requiring vasopressin. We are going to assess them at least to identify whether we are going to identify those with catecholamine resistant shock. These are patients who are relatively deficient in angiotensin. This is what we are trying to find out. I spoke about this. The type of fluid also has undergone a lot of paradigm shifts from 2012 to 2023. But most importantly, there is no advantage of giving balanced crystalloids in the early phase of resuscitation. Hyperchloremia also becomes a problem only after you have completed your 30 mils per kilogram fluid resuscitation, and more fluid resuscitation is required. Steroids have never actually gone off the shelf in the ICUs. There are pros and cons. The Anani article of 2002, the Corticus study, the Apricus study, the Adrenal study, they all have given us vague answers saying in a selected set of patients, steroids may still have a role, but none of them have been able to clearly identify and tell you and me which is that some subset of patients in whom steroids would work. So it is probably this patient who is fluid resistant, vasopressor, catecholamine resistant, who requires a third vasopressor for maintaining his mean arterial pressure. That may be the patient who will actually deserve to be treated with hydrocortisone. But what we do know is that you cannot give more than 200 milligrams per day, and probably a sustained infusion is superior to intermittent dosing of these patients who are on high dose of vasopressors. Now, acute kidney injury. This is a bidirectional paradigm. Sepsis produces acute kidney injury, which we all know, and we all understand the pathophysiological mechanisms of sepsis and AKI. You have oxidative stress, you have the molecular pattern related damage, and you have the hypoperfusion as well as the microvascular thrombosis, which we now have understood post-COVID. So we fairly know that sepsis and acute kidney injury are the cause and effect relationship. But we should also understand that acute kidney injury can itself trigger a systemic inflammatory response. Acute kidney injury is not a single organ dysfunction. It is a multi-organ syndrome as a standalone. It triggers its own inflammatory response. It triggers its own respiratory, cardiac, and hepatic problems. So when you have a patient with sepsis and acute kidney injury, you expect other organs also to be part of this crosstalk and get involved in this in the damage that happens with sepsis. So when you know that there are cytokines, there are mediators of inflammation, there is a peak and spike, there is immunoparalysis, the natural thought process that should come into your brain is, can we remove these inflammatory markers and therefore improve the outcomes of patients with sepsis? And that is where extracorporeal blood purification comes into the picture. But quite disappointingly, none of the extracorporeal blood purification techniques have shown to improve mortality consistently across all subsets of patients with sepsis. So you have convection therapies like CRRT, high volume hemofiltration and high cutoff membranes. You have absorption therapies like the cytosorb and the endotoxin adsorbent columns like the polymyxin and the oxyphil. You have combination therapies and you have other therapies, plasma exchange, renal assist device. They have been shown to reduce the vasopressor requirement. They have been shown to reduce the cytokine levels, but they haven't yet translated into mortality benefit. So the intervention with removing a cytokine with a device does not seem to be evidence-based at this point of time. Probably more work is needed for this aspect. So lastly, we should look at the phenotypes of sepsis. So sepsis has several phenotypes based on the metabolites, the mRNA profiles, the cellular function, and the protein signature. So you have several endotypes of sepsis that some patients come to you absolutely in the dumps. That means there is no blood pressure, high lactate, multi-organ failure when you see them for the first time. Those are the patients who are immune exhausted. Their immune system is already exhausted. Then those patients who come with fever, tachycardia, systemic inflammatory response, leukocytosis, high procalcitonin, those are the patients who have the hyperinflammatory innate response. There are patients who come with fever, with leukocytosis, but they do not have that exuberant systemic inflammatory response. Those are the patients who have balanced T cell immune response and are able to fight their infection, so they probably have the best outcome. You have another subset of patients who come bleeding with sepsis, right? They may not have liver dysfunction, they may not have acute kidney injury, but they come with coagulopathy, thrombocytopenia, raised INR, raised APDT. That is the endotype of sepsis who come with deranged coagulation. But this coagulation, as I said, you have to trace it back to the cytokine storm. So this is the endotype of sepsis, which ultimately results in several phenotypes of sepsis. So the phenotypes you need to understand about sepsis are that there are patients who come with a hyperinflammatory response, very high fever and systemic inflammatory response. There is a phenotype of sepsis who comes with predominant hypotension. There is a phenotype of sepsis who are fluid responsive, and there is a phenotype of sepsis who are fluid unresponsive. Even with 20 mils per kilogram body weight of fluid, the third space, they become edematous, right? There is a phenotype of sepsis who will have early ARDS, who will have early acute kidney injury, who will have early myocardial depression, right? And there is the last unfortunate subset of patients who will die despite all the aggressive organ supports you give. So this is the understanding of the phenotypes of sepsis. If you look at the landmark paper on phenotypes in sepsis, you'll find that big circle, this big circle. So you have the alpha, beta, gamma, delta phenotypes, and you can see that the gamma phenotype has extensive inflammatory response, but very little hematological response, but inflammatory and pulmonary response. But if you look at the delta phenotype, you will find it has extensive cardiovascular manifestations and probably a little bit of inflammatory response. So if you look at the beta phenotype, the other organ dysfunctions, like your liver dysfunction, for example, your CNS dysfunction, for example, are more common in the beta phenotype of sepsis. So this is how you need to triage your patients so that you prioritize what intervention is going to be most effective for these patients with sepsis and septic shock. Probably with the use of machine learning and artificial intelligence algorithms, this is going to be the way you are going to triage patients and allocate our resources in the emergency room maybe 4 years or 5 years from now. Lastly, I speak about the diagnostic tools. You should know about the diagnosis of sepsis because it's been an essay question in the last couple of years. So you divide the diagnostic tools into conventional methods, modern methods, and advanced methods. You know that the conventional tools are blood cultures and biochemical tools. We know them. Modern methods are molecular diagnostics and antimicrobial resistance pattern detection with PCRs and MALDI-TOFs and DNA microarrow, but MALDI-TOF at this point of time depends on a positive blood culture. So there is still going to be a time lag, but once the culture is growing something, your timelines for getting the resistance pattern is probably shorter, but it will still be 48 hours. The advanced methods like biosensors are the ones which will use artificial intelligence algorithms and will tell you the moment a sample is sent to the lab, they will tell you that this is probably the organism and this is probably going to be the resistance pattern. That is what is biosensor method. Currently it is in the lab. Probably in the next 10 years, this is going to come to the bedside. Just as you now have the butterfly ultrasound machine where you can carry around in your ICU, you will get a point of care device like your ABG machine in the ICU where you feed a blood sample and you can see a display of what phenotype of sepsis you are dealing and what organism with what resistance pattern is the most common cause of this particular syndrome. And sepsis is not an acute phenomena, right? Just like you have chronic sequelae of ARDS, you have chronic sequelae of AKI. Sepsis also has a chronic sequelae. Somebody who survives sepsis in your ICU and goes home is not going to be a normal person forever. There is going to be a long-term sequelae of chronic critical illness. These patients are more prone for immunosuppression the next time they have an infection, and they are more prone for a catabolism syndrome when the next insult comes in at a lesser level of inflammatory response. So this is something we have now understood. There is going to be a chronic illness associated with the survivors of sepsis. So in summary, the understanding of sepsis is improving, but it's still incomplete. It will take maybe another 20 years. There is no clear evidence to support the default use of balanced salt solutions. Conservative fluid strategy after initial resuscitation is the best way to do it. Early initiation of vasopressors if your initial MAP is less than 45. Steroids to be considered in selected situations. Angiotensin II provides some hope as a third vasopressor. Extracorporeal blood purification techniques have not been shown to be any benefit in terms of survival. Molecular diagnostics combined with artificial intelligence may bring point of care testing to the bedside for better management and outcomes of patients with sepsis.